welcome to another edition of the Survive It COVID-19 series, which seeks to support advocacy of COVID-19 and how we can all stay safe. The scientists and medical practitioners tell us all the time they are yet to fully understand how the SARS-CoV-2 virus operates. There is also no known cure. Neither is there a vaccine. The only way we can stay safe is to avoid catching the virus. So keep your face mask on while in public, and they should always cover your nose and your mouth. Wash your hands regularly and sanitize when you can't, and keep a physical distance. Simply put, assume that the next person you encounter could have the virus, so do what you can to avoid catching it. And keeping a physical distance does not mean you're shunning the person. It's because of the times in which we find ourselves. If this is your first time joining us, there are 3 other shows you've missed, but which are available on my YouTube channel. Just go to Israel Live on YouTube. This show will be uploaded once we're done. Today, we want to spend some time looking at the data and science informing the policies being implemented by the government of Ghana to contain the COVID-19 pandemic. And we're looking at it in its entirety from the beginning, when we took measures to prevent the importation of new cases with the closure of our borders, the imposition of the lockdown, the lifting of the lockdown, and the gradual easing of restrictions to the point where schools were open for final year students to go write their exams. The president has always maintained these decisions have been supported by the data and science. What are these? We'll also look at our testing regime, how much testing we are doing now, and how does that compare with what we used to do some months ago? Are we getting to a point where we can say we're bringing the pandemic under control, and what is informing that position? The hydroxychloroquine controversy has also surfaced. What is the policy on that here in Ghana? Joining me this morning via Zoom, I have Kwame Sarpong Asiedu, a pharmacist based in the UK, who is also fellow of the Center for Democratic Development Ghana, and Dr. Bediako, an immunologist and research fellow at the West African Center for Cell Biology of Infectious Pathogens, WACCBIP, University of Ghana. Also, I'm hoping that he will join us shortly, the Director General of the Ghana Health Service, Dr. Patrick Kuma-Aboagye. It's fair to say he's the top expert in charge of the fight against the pandemic. So we're anticipating that he will join us shortly. Immediately he joins, he will be a part of this conversation. Together, we'll be interrogating the science and data informing Ghana's COVID-19 policies. Now, I want us to start off with the cases that we have at the moment. So we have just been reported by the Ghana Health Service, 787 new cases. That's reported for July 30. And then, even though not stated clearly, another 726 cases for July 29. Together, we're looking at a positivity rate of 28%. Meaning, for every 10 suspected cases, 3 are likely to be positive. So we'll be going into that. I want to start with Kwame Sarpong Asiedu, who has been doing some work on this consistently. He's been crunching the figures. He's been looking at the figures and interrogating the figures. And he is joining as someone who's followed this keenly and who's also been monitoring the figures as put out by the updates as put out by the Ghana Health Service. So Mr. Kwame Sarpong Asiedu, I want to start with you. How did you see the figures that were published this morning, the 787 new cases and the positivity rate?
Well, thank you, Israel, for having me, and good morning to Dr. Bediako. I must say I was concerned, and my concern comes from a WHO release around testing and positivity, which is clear to say that if your positivity is above 5%, there's cause for concern. But overall, when it's between 3 and 12%, you can still manage. It means that you are not testing as much as you should, but you are probably there or thereabout. But the minute your positivity goes above 12%, then clearly you are not testing enough because there's more community spread than you are capturing. Consistently, if you go onto a website like Our World in Data, which is run by Johns Hopkins, Oxford University, University of Cambridge, MIT, and the lot, who've been churning out these numbers, because initially we were churning out the numbers. And then we decided that, oh, let's see what others are doing. And now you realize that they are more consistent because they churn out almost everything, from our effective reproductive number, through our doubling rate, through our positivity, through our prevalence rates. Everything is on Our World in Data. So you can just see everything clear on a daily basis. And if you look there on the map, Ghana is one of the countries marked red as not testing enough. I mean, I can see you're checking it. If you go there and you look at the positivity, you'd see that Ghana is marked red because our positivity in the last 4 weeks has been consistently above 20%. So in that sense, it tells me that we are not testing enough.
All right.
But as we started testing more, because at that time, when we started going into the late teens, early 20s in the positivity percentage on a daily basis, our testing numbers also were coming down. We're all aware that the Ghana Health Service had said that we're having issues with obtaining reagents and PCR testing and all that. Currently, our testing numbers have gone up. Again, if you look on Our World in Data, you see that we are hovering around 4,005 tests a day. And I would have expected that because that's the denominator, as the denominator goes up, and the positive tests are there, you would get a lower positivity test percentage. Unfortunately, that hasn't happened, which is another indicator that there's a lot more community spread, because even our current denominator is not capturing the number of samples we need to take for us to be in the WHO range. Situating that, therefore, you then realize what sort of testing do we need to be doing, probably to get us within the 3 and 12%. And if you do the maths, it's about 9,500 tests a day. But this is where it gets interesting, because we all have to realize that the PCRs are costing between $65 and $100, depending on where you look at. So you're talking of something upwards of around $65,000 to $95,000 a day for an indefinite period of time, which is a huge cost for government. So this is why I worried about the numbers that we put up, because the positivity is high. We've got to do something about it. But to do something about it would incur a lot of cost from a test point of view. How we navigate these two paradigms is what we need to look at.
All right. Now, thankfully, Dr. Patrick Kuma-Aboagye, the Director General of the Ghana Health Service, has joined us. So he will respond to that. Now, Doc, thank you very much for making time. So one of the concerns that has come up, and which has been raised by Kwame Sarpong Asiedu, and which is something I've also been observing for a while, is the fact that it doesn't look like, I don't think that we're testing that much. In fact, it's not me thinking that, but if you look at the numbers, sometime in May, on May 12th, I believe, we tested about 12,000 samples a day. But right now, we're doing on the average about 3,000, 4,000, 5,000 thereabouts, and which is the issue that Kwame Sarpong Asiedu is here. How do you respond to that?
Yeah, good morning, and good morning, everyone. I believe, thanks for the opportunity. I believe that we have all agreed that this is a platform that I want to use to advance the cause of our fights, and not just punch holes without making suggestions as to how it can be done. And that's why I agreed to join this platform when you invited me. Okay, so yes, we're not just testing holes. I'm sure the suggestions will come. Yeah, but also bring suggestions as you do for other countries and others. And that, I think the purpose is to all of us to advance our fight with the virus. Sure. I believe that we also know that this is a particular condition that has affected even the mightier nations. And so you have to look at Ghana within that context. We have a testing policy, and that testing policy means that you are testing. We started the initial testing policy because we're looking for evidence to community spread, we started with importation. So we tried looking for community spread. So we just did a circle around communities and tested to see whether there are any positivities in that area, especially when we find the positive or so. After establishing the community spread, we have moved all away from that. And we have also been, we're the very first country to do what we call enhanced contact tracing. Ordinarily, you would have just waited for symptoms before you test. But we tested contacts immediately they are identified. And so that's what we call the enhanced contact tracing. We continue to do that. But we test people with symptoms as is routine cases. We test their contacts. We identify risk groups and test them and follow them up. And so based on that, that is what is driving our testing policy. We had a lot of erroneous things when people were just rushing to go and test because Joy FM gets one case and they want everybody in the office to be tested. And so you start seeing those numbers go up, and of course, your positivity rate will come. So now we will see that we are doing different approaches now, because now we are doing routine cases, we are doing other, and then their contacts, students, those who are bringing in quarantine, you know the policy. And so that is what driving the number of tests that will be done. Yes, somewhere in May, we had June, we had challenge with the availability, not because the state didn't have the resources to buy, but we just couldn't even find them to buy. And we came clean to the people and said that even then we're doing about 2,000 plus tests. Now that we have that, we have gone back to do some of the backlogs, and then we are doing more tests and more. Our approach is not just to do more tests for testing sake, but also how making sure that people get their results on time for us the response to be appropriate. Countries who are not testing, what I show is if you are not testing, it's working. So if you are saying you are not testing, and so people are walking around the community with the virus, they should be appearing in our facility with conditions where the symptoms, if you have become breathless, you come. But in the meantime, what are we seeing? We are having our case, those on treatment coming down, those on admission continues to come down. About 90% of all our cases, I would say, are asymptomatic, which means that we are even testing people who did not show signs. So basically, that is what we are doing. If you want to compare things, and I believe that we are making some good progress with our testing. The most important thing is people protecting themselves. And once you are able to get the population to wear the masks and do the protest.
It looks like we have lost Dr. Patrick Aboagye. It's Sarpong Asiedu. You've heard the Director General of the Ghana Health Service. He feels that, well, yes, we should also come up with some ideas and suggestions as to how we can improve our situation or improve on our fight. And I would want you to come up with some supporters with some suggestions as he has advised. I think he's joining us, and hopefully the connection will be better now. So please bear that in mind so that we can have your suggestions. As he gets ready, okay, so Dr. Patrick Aboagye, now that we have you back on, you were making the point about the fact that, well, yes, there's a new strategy that's guiding the number of tests we're doing. Well, and that's fair. But the question I have, and I'm sure what many others would have, is that we used to test so much more when we had few cases. You said we did that to establish that there's community spread. But right now we know there's community spread, but we have our cases going into the tens of thousands. We have more than 30,000 now. Shouldn't we be testing more, even if we're doing we're using the strategy that you're saying that we're using?
We are not dealing with a chronic condition. We are dealing with an acute condition. So the cumulative figures is not very relevant. The most relevant indicator is that how many people are positive.
Okay.
So what I'm saying is that ours have always been a lot of classes. We are dealing with more classes. The rest have just been classes around. And so it's not a generalized spread that we are dealing with. There are many districts in the country that have not had any case before. And so our testing is just hovered around it, and that's why we are testing tests. And that's what's going to dictate the number of tests that gets done.
All right, you indicated earlier that there are some districts that haven't had any positive case in a while. But the question I have
not in a while. No. Not in a while. Since the beginning,
they've never had a
pandemic.
positive case.
No. We have more than 40% of our districts in this country that has not recorded a sin. So we are not dealing with a generalized so we need to manage it within the context that we are in now. We've had outbreaks in Obuasi, we had them in Tema, we had them in Wasa-Memfi, and we respond to them while dealing with the generalized ones that we are dealing with. So people must have an understanding of what we are dealing with, okay? And not say that the population is 30 million, so you have to test this number of people. That is what we are dealing with.
Doc,
is it so bad? Can you hear me?
Well, yeah, I can hear you. Doc, my difficulty, and I'm just looking at it, I'm not an expert, I'm not an epidemiologist or immunologist, but I'm just looking at the figures. I'm looking at 37,000, and I'm looking at the positivity rates that we're recording in recent times, and I'm asking myself, if we're not testing as much, it doesn't mean then that the 37,000 that we have a lot more people with COVID, but because we haven't tested them, we don't know. And so the 37 cumulative cases or the active cases, which is hovering around 4,000, may be understated.
No, I think in all this, we are always able to do some projections as to what is the prevalence rate or incidence rate of the condition, because no country is testing everybody. No country is testing everybody. And so if you are looking at people who are coming to you with signs and symptoms, which means that your also positivity is going to be high because you're focusing on the sick, okay, and their contacts. If we just start driving testing, you're going to have a positivity that is going to be low, because you're going to test people who have not, the risk levels are low, okay? So that's how it has to be. That should not like it to be positive. Even this will give you an indication that even for those who are sick, larger in their contacts, if that's what we are getting, and the risk group, which means that the general population may not be as high as one thinks. And that is what we continue to hammer on to people that I keep telling that there are many districts in this country where they have not had a case. If you go to Upper East now, they have no active case. Northeast has no active case. It doesn't mean they are not testing. There's Nabrongo research that continue to do testing. They are negative. And not just this, the whole region has no case. Okay, so it is, we need to look at it within our context of how we are. It's about movement, it's about activity, etc. And so that's how we are managing it, that the way we say. So it's not a question of just at that price and then, basically, I think that's what we need to do. And I can keep telling you, if you hide from testing, then people will appear sick. And you can't hide that one. You can't hide that one. Those who appear sick and die, you can't hide that.
Yeah.
If you are not testing, they will come.
But Doc, we also know that you've already stated that we have a large number of people who are asymptomatic. And so there are people who would live their lives and never have symptoms and think that, I mean, they only know that there's anything wrong with them. But then
there is a percentage, there's always going to be a percentage of other people who appear sick. So if you are not testing, that percentage will appear. You can't hide it, they will appear. You go to the US and everything. they come in before they are tested, sick before they are tested. And so you will find them. So you can't run away. If Upper East hasn't got them, you can't run away from that. And so let's look at it within our context, and let's see within the resources that we have, within the context that we have, how best can we advance our distance instead of going to compare with all other platforms that are doing. In those platforms of the 100, almost 200 countries, where is Ghana's position on that? There are many things that we've done. We came with a recovery policy. Everybody came to condemn it. Now the whole world has adopted it. Pooling, the same story. Enhanced contact tracing, the same problem. So even when we open schools, we should not open schools. Nigeria has closed. Nigeria is opening. Now they are just copying Ghana. And so I think we need a lot of support and encouragement to do what we are going to do.
All right, let me go to Dr. Bediako. He is an immunologist. Doc, you have also been observing what's going on. Dr. Patrick-Aboagye is saying that we should look at it within our context. How would you situate it within our context, and not necessarily having to compare what we're doing with other countries are doing and expect that they do same, we do same?
Thank you, Israel. I mean, I think, yes, we have to always consider these issues within the local context and within the financial means of a country. We are not, I don't think anyone is expecting Ghana to be testing on the scale of, for instance, the US or the United Kingdom, given that we have fewer resources. Having said that, I think we have to constantly be viewing our outbreak and seeing if we are doing the best that we can do. I think some of us who look at the testing, I think it's been published that Ghana has a capacity to do over 8,000 tests a day if you put all the testing facilities in the country together. So Noguchi can do over 4,000 a day. Navrongo, incidentally, can do about 100. Tamale 400, and so on. So if you put all the testing sites together that have been equipped by the government, we are, and including a couple of private ones that are now, like Nyaho Clinic and others that are now coming online, we can do roughly about 8,000 tests a day. Now, of course, there's an economic cost to that. These tests are not cheap, but if we are doing on average between 4,000 and 5,000 a day, and we are not using 3,000 of our capacity. Given as Kwame has mentioned that we are around, we are hovering between, we are over 12% of our tests being positive, sometimes almost up to 20%. It feels as though, it begs the question of, well, since we have that added capacity, why don't we just test? Why don't we make use of that capacity? If we get to 8,000 and we, no one is saying we should go to 20,000, right? But we have capacity to do 8,000 a day. Are there not ways that we can find the means to do those 8,000? Because while I fully acknowledge that we won't test everybody, that no one is testing everybody, you have to do samples. You have to do representative samples. And so the question you ask is, for these districts that have not recorded cases, how representative has the sampling been in those cases? Like I just said, Navrongo, per the government's own documents, can do 100 tests a day. Now, I don't know the population density up north. I'm sure it is, it's probably a little less than what is down south. But still, if Noguchi can do 4,000 and Navrongo can do 100, you can see how we would very easily catch many more cases in Accra than we would in Navrongo if we were just sampling. So,
Dr. Bediako, the issue that Dr. Patrick-Aboagye is raising is, who should we test? If we're not testing everybody, the Ghana Health Service decides that let's target some specific, the people who come in sick and their contacts. We prioritize some students and a few others. What would you say should be our approach?
I mean, I am not privy, Dr. Aboagye is much better positioned to describe the actual policies that the Ghana Health Service is implementing. But Mike, I guess the question I would ask is, of course, I think we are currently trying to test everyone who presents with symptoms. And so that is the first sort of step. But beyond that, when we think of contact tracing, how wide are we going in terms of contact tracing? You have to draw a line somewhere, contact over contact and so on. But I think that in certain cases, sometimes based on the availability of resources, we don't necessarily always test every contact. Could those numbers be increased? And I fully agree with Dr. Aboagye that we are dealing with clusters. So perhaps we need to have strategies, targeted strategies in certain areas where we will do more extensive contact tracing than in other places where perhaps we find that the clusters are much more diffuse and we don't really have significant density of testing. So I think it's an evolving situation. I think Ghana definitely should be commended for what we have tried to do. But I guess the feeling that I have and maybe other people have is that we should keep pushing, and perhaps be maybe even a little bit more transparent with how many people are being tested in every region. Right now, we get a broad number that says we've tested this many people. It might be helpful to actually see the breakdown so that people like us who are not privy to all the data that Ghana Health Service has access to would understand that, oh, actually, they did 1,000 tests in Upper East and there were hardly anybody positive. And so it makes sense to maybe scale down the testing. Whereas in Greater Accra, maybe they tested 5,000 people, 3,000 were, whatever number were positive. And so we need to increase the testing there. I think there's a call for a little bit of greater transparency, but I fully agree that we need targeted approaches. It's not a one size fits all. And certain regions will require more intense testing than others.
Kwame, you've heard Dr. Patrick Aboagye. He doesn't think that we should, in fact, everybody agrees that we shouldn't go about seeking to test everybody. So we should have a targeted approach. You know how Dr. Patrick Aboagye has talked about how they intend to go about it. Do you have any issues with that?
Thanks, Israel. It's not really issues. Like Yao just said, when you're doing contact tracing with any outbreak, there's something about the generational time, which is the time it takes for an infected person to infect the next person and for that person to infect another person. For SARS-CoV-2, it's about 1.5 days. So the first thing I would suggest is that if you are testing and the results are coming after 4 generations, which is between 6 to 8 days, the chances are that the contacts might have infected other people. So if we could cut our test return time down, because we all know that any infected person would be infectious and contagious for up to 8 days, plus or minus 3 days. So it goes to up to about 11 days. So if you allow that person, or even if that person is sick and has come into hospital, so has been hospitalized, but their contacts are still in the community, the chances are that the longer you take, the more people they would infect, even with all the protocols in place, wearing face masks, because we know that some people are not adhering to them. So that would be the first best thing. The second thing I would say is that, and I've been saying this for months, that apart from a pure prevalence and understanding of how the disease has progressed in the country, anything after 14 days of testing doesn't actually help the Ghana Health Service fight. And I'm glad that Dr. Aboagye has said in a previous press statement that they were not going to prioritize those ones. But we need to realize that with our discharge policy, it would then be important, if we don't have the resources, to either abandon those tests until our positivity is coming down. Because if the person has been there for 4, 5, 6 weeks and hasn't got their results, 1, they are not contagious, and 2, they would have been very sick and got hospitalized. They would be hospitalized by now. So if we don't have resources and we are testing 4,000, then let's concentrate the 4,000 on people whose samples have been taken in, say, the last 3 or 4 days for a while. I know that people would have issues with that because people want to know their actual total cumulative numbers. I can understand those who come from a public health fight point of view. I don't see the real relevance at this point in time. Then I would go to another thing, which is around our active cases. If you look at our discharge policy clearly, it says that we are discharging within 14 days, which means that technically, if you ignore all the tests that have been done, there's people who've been tested till now, our active case count should be approximately equal to between 10 and 14 days of the number of results we reported. But if you do the maths, our active case count is actually about 5 days. And that is because a lot of the samples we are reporting are out of the 14-day time window. So if you look at yesterday's reporting, for example, it was about 32 days. And therefore, what's happening is that those ones are rightly being added to the discharge and recovery. But in effect, they are not helping our fight, if you ask me, because at the end of the day, they are not making any impact with the disease trajectory and understanding. So when you are stuck with resources, you've got to be prudent around some of these things. And that has been my position. And that's what I've said. And Israel, you've been reading my post. I have always talked about this prudence. And anytime I've written to expose the gaps, I've in conclusion said clearly what I think needs to change. Anyone who's read me on social media will be clear about that. Every time in my last paragraph, I'll say about 3 things that I need to change, like I've just said here.
All right.
If we do that, then finally, we would come to realize that our positivity that is above 12% would probably start dropping because we wouldn't have that many generations for the community spread to continue. So if we can cut down that lag time between testing and reporting, decrease the number of historical tests we're doing, ensure compliance with the protocols, and strategically isolate these people who are actually contacts of the ones who've come into hospital are unwell, especially in the pockets that we have, like in Accra, Kumasi, and other places where you occasionally would see a flare-up. That would be helpful as far as I'm concerned.
All right, Dr. Aboagye, this conversation about historical samples and how to deal with them, it's something that we have privately discussed, but it sounds like a plan, don't you think?
Well, thank you very much. I think we have already mentioned the fact that I'm not going to be prioritized. Those that have been done already before the policy change was done. Like I said, we are not going to abandon them, just never positive. And so, but our shifts and our emphasis on what we are doing is about to improve the turnaround time so that within 48 hours, you get your results. And in terms of the numbers, I can tell you that we have on the average about 11 contacts per case of positive. And so you don't have, for example, so one cannot say, oh, they are not testing contacts. We even know that on the average number of contacts per positive case. And that can also project to see that the number of tests we are doing, whether it corresponds with what we are doing. See, if you just go on the websites, you have issues. Israel, you know that there are district situation reports, regional situation reports that you journalists have access to, isn't it? And so every region will tell you, today we tested this number. These were the positives. So what we have is an aggregation on the website. So that if you want to tell you how many tests were done, how many were positive. And so we have an aggregation of that. But of course, on the website, you can't put everything in there. And I keep telling Kwame and his team that when you want further information, I said, it's not information, just put it out there. And so we have the information. So we are being very, very transparent with our figures because we want the solution. We are not going to hide anything. We want everybody to help us. And so, like I said, the testing policy is what is going to drive the number. So if today you have 200 positives, is their contacts you're going to go after? We have situations where people were, because we when we go and test 1,000 people, it started creating a clog, and that was going to delay on the turnaround time was being affected. And so those ones to do 1,000 and probably about 5 of them are positive, you know, so you can look at But these are people who, based on other contacts, we could have been identified. Because that's the best bet for us to be able to respond, because the most important thing is to identify and isolate. And if you can identify and isolate, then you are just like running through a dark tunnel. You don't know where you're going to go to, because you just be chasing the cases, because before you are able to contain one, it's infected 11 or 12 people and you are chasing them. And so that is what our aim is. And so when we are cutting off unnecessary tests, it is also to allow us to be able to improve our turnaround time. Well, if you just start testing everybody in the market, you see, and so like I forgot the name. Immunologist said it's about the local context. What is our local context? That's what we need to really focus on. And I believe that we are also very, very, very eager to control this thing. Everybody is running. The economy is down. I mean, how long are we is affecting the economy? How long are you going to continue if you don't contain it properly? How long can we continue responding? Context. And that's why with our focus, relatively higher positivity rate, because we're getting the contacts and the cases. And so that's why you get it. But as we see flare-up, there are districts that we've done a flare-up in Wasa, Amenfi East. You go there, you isolate to make sure you create an isolation center, and we contain that. We did the same thing on Obuasi. There was a mass cases there. We moved in there, we test as many people, identify a testing center, a treatment center, and it's under control. So that is how the strategy has been. You see, and all the streets, you see, and remember there's an active surveillance going on. Very, very active surveillance going on. And the Ghanaians are very, very, I think he's from Togo, he has somebody who is coughing. And so these are the sub-districts, the CHIPS compounds, the district level, they are all on the ground. And that's why every day they are all able to report, and we're able to aggregate our results and share with the people of Ghana.
All right, joining us also in this meeting is Dr. Asiedu-Bekoe. He has his hand up, so let me give him an opportunity to make a point or a comment.
He is the head of surveillance. He's the one who's doing the numbers.
All right, so let's hear him. Dr. Asiedu-Bekoe. Hello, Dr. Asiedu-Bekoe.
Maybe ask him to unmute.
Yeah. I'm still having. All right, so whilst we get him to get ready to join and talk about the surveillance, and I'd want to believe that, Doc, if he is not there, you're saying that you'd have to leave at some point, so we can have him join us, continue the conversation. But you mentioned economy, and it brings my mind to the issue of the data and science.
Yeah.
Are we having to consider the economy in our decisions or in our data and science decisions rather than actually using the hardcore data? Or are we having to find a compromise between the data and science and saving the economy?
Well, thank you very much. That is not for me to make those decisions. We are following the science and providing the information. But we also know that even the resources we need in responding will have to come from some resources that. You see, this COVID is either you get the virus or you get the effects of the virus. Or if you are not lucky, you get both. Okay, so to spend so much on wash facilities, we are also having an issue of people not coming to hospitals because of perception that I might get some disease or they don't have time for me. And so even the health impact on health itself is part of the problem. People are not coming, and so people who are hypertensive and who should be coming for their daily care may not be coming. That has also its own ripple effect. So you cannot just consider the virus as on its own, but you need to also look at the effects and see how you manage.
Dr. Bediako.
That is why we need to be very aggressive and make sure able to look at that. But in terms of balancing the economy with science, that's not our job. Our job is to provide the information on the virus and how it's behaving and how we are containing it. And of course, there are other people there who have the responsibility to manage the country to put all that in context.
All right, so regarding the data and science, which you're saying that you provide the evidence and the facts, and then you let those who have to take the decision, which will be, well, the president and his team, to decide. One of the issues that has come up in recent times has to do with the opening up of public transport, and so that we stop social distancing, so we can fill the buses with full capacity. There are people who are questioning the data and science that supports it. They say, why do we allow full capacity trotros people to sit in full capacity trotros and get to churches where they're supposed to social distance? People have questioned the data and science regarding that.
Israel, if I'm standing by you and talking and singing and screaming, the risk is different from sitting by me and sleeping or not talking, not holding hands. And so the issue that if you could do that comparison, the activities within the context, within the area of where the service, whatever is taken, whether it's church or a club or whatever, it's what informs the risk. Our experience from the beginning of the pandemic, having followed all our cases who are positive and following their contacts, their transport and trotros and everything, we are yet to come up with anybody who have picked up the virus from etc. We track all of them. We've not been able to see anyone who has had it.
Look, have we been able to successfully?
The important thing is that the amount of virus that yes.
Yeah, Doc, I'm saying
Hello?
the question I had for you is, have we been, you talk about tracing the contacts in trotros and the rest, have we been successfully able to do that? Because I can imagine it's going to be a challenge, tracking or tracing somebody's contacts once they sit in a trotro. And for me, I feel that if we have been able to track or trace them successfully and tested them and found that there was no infection, then we can say that, yes, indeed, if you're sitting in a trotro and you don't social distance in a trotro, you're not likely to pick up an infection.
That's exactly what I'm trying to search. And even the trotro, the contact time is even shorter. We have had people from Kintampo to Kumasi, Accra to Wa, to Narugu and all those places where we have been tracking. You see, at the beginning of the pandemic, one of the first things we did was to get a DPRTU to register, take on register of all the people who bought their pass. Okay, and so we are able to follow VIP, etc. And we've not come up with any strong evidence that the risk is higher. So the risk levels in those, it's more to do with the activity that you do, not necessarily whether you are sitting next to. I'm sure you have come around people. It's not about that really important. From our evidence for now, about we've not been able to identify even drivers who we know are positive. We've not been able to identify any of their passengers who have ever turned positive. Because sometimes we catch them, we get them, they are positive, we call them, we go and stop them. And then we are able to follow up the people they were in their vehicle with over days, and risk is higher. And that is why we feel that we may have to have a different scenario for them, especially when everybody in the car is expected to wear their mask. And it's not just social distancing that has been all the time, and everybody in the vehicle is supposed to wear masks. What we need to do is to ensure that that is respected.
Right, Dr. Bediako, would you have a point to make here? And Kwame Sarpong Asiedu, because at some point Dr. Patrick Aboagye says he would have to leave.
I mean, I think the issue with the trotros is one. I mean, I take Dr. Aboagye's point that they have managed to do some contact tracing of passengers and haven't discovered transmission. Although, you know, I would also say that there have been studies, you know, actual sort of scientific studies done in, not in Ghana, but there were 3 that I could find done in China, specifically looking at transmission within buses. And these have demonstrated that there actually can be transmission. Now, of course, it is true that if I'm singing in a church or I'm talking loudly, I'm much more likely to produce droplets than if I'm sitting quietly in a bus. But we do also know that not everybody who sits in a bus sits quietly. The mate is always shouting, Accra, Accra, Madina, Madina, and all of those things. So I think that...
Wearing masks.
But
wearing masks.
Well, not all of them wear masks.
Supposed to be wearing masks. Today, I did my own unscientific study on my way. But I think
the protocol is yes. Okay, go ahead.
Yes, but I think that, you know, I fully agree. The protocol is they should wear masks. But what I'm saying is, on my way to my office this morning, I did my own unscientific study, and I looked in every single trotro I drove past, and I found not a single trotro did I find that I found at least one person not wearing a mask in every trotro that I looked at. So adherence is a problem. And I think that is where some of us would say, yes, in a perfect world, if everybody was wearing a mask, then potentially the risk within trotros would be lower, and you might be able to get away from the social distancing. But we know the country we are in. We know that, you know, people are human. It's not just about Ghanaians, it's anywhere. There will always be those who are non-adherent. And so the argument on the other side is it worth the risk to say that since we know some people will not wear masks, then should we still go back to full capacity? If by saying they go on half capacity, potentially we minimize the risk, knowing that some people would not adhere to the mask wearing. So I think that is the challenge. I understand that the risk profiles in different activities are different, but I believe that there can be transmission in buses. It has been shown. Yes. Of course, if people are wearing masks, it is minimized, but then we have to temper that. As Dr. Aboagye has said, it's all about context. We are in a country that temperatures are warm. Trotros are mostly not air conditioned. It's uncomfortable to wear a mask for a long trip in the middle of Accra in the heat of the sun. So some people will remove their masks or at least pull them down to their chin. That means the risk profile now goes up again because now they are not properly protected. So as custodians of our health, the question is that should we not then try to help these people by saying trotros are only going to be half capacity. So even if people don't wear masks, there's less of a risk. So the burden is always on the individual. I agree. We have to be responsible for ourselves. But I think by putting trotros back to full capacity, we are putting greater burden of responsibility on individuals. And the question is, are people abiding by these? Because ultimately, if this virus spreads, it creates a problem for Dr. Aboagye and his team because they now have to deal with other people who potentially would get infected. So that is where I differ slightly. My feeling would be, we know people won't always wear the mask. So maybe we shouldn't let them all sit in the bus because they won't listen to us when we say wear a mask. But that's just my point.
Dr. Aboagye.
Well, Israel, I think there's the need to get a very good balance. When we said people should go and finish their exams and come home, we knew there was a risk. But you need to look at the risks and benefits. And I believe that we need to continue to encourage people to protect themselves. When we say living with the virus, we need to look about, we will continue observing to see if there's any trend that needs to be revisited. We'll revisit it, but we need to also encourage people to take responsibility because you see, what creates a problem is that if the tractor driver is also not breaking even, they are going to create other avenues that will create more challenges for us. And so it's about vigilance and ensuring that everybody looks at that. And I believe that in the last 3 or 4 weeks, we are seeing an increasing adherence, especially to the mask. Okay, and I think that's what we need to continue driving and making people more responsible to protecting themselves. And then we will continue observing. If there's any reason why we have to revisit that advice, we'll revisit that advice.
All right.
See, but for now, from all the evidence that we've had, all the experience we've had, we felt that they could manage.
Doc, is Ghana getting to the point where you can say it has a handle on the COVID-19 pandemic?
Well, in the last few weeks, you can see that the numbers continue to come down. If you've been looking at the moving average, you see that it's gone up, but then we've been having a continuous decline currently. So we are hoping that to continue going down and stay down, or even get to the 0 points. But then we have to ensure that we stay our active cases and the number of positive remains low. That becomes, but for now, looking at where we were end of May, June, and mid of July, I think we are on a trajectory that we are going down, and we hope that one will continue. And we've had about 4 regions that have not been reporting cases, and not because they are not testing. If you look at the data, you see that tests are going on in Western North, tests are going everywhere. Good as a mind, it's just a cluster. And that's what we are having to deal with. But I think we are, if you look at the charts that we are sharing on the website, you can see that there is a gradual decline on the kinds of positives that we are getting.
All right, so Doc, I look at the figures, and I look at the positivity rate of the new cases, and I don't get that level of comfort.
Well, you see, it depends on how sensitive your case definition is. You see, if you decide to just test everybody, the positivity rate will come down. And you'll be as if, the rate will come down. And that's the contrast that we need to look at it. If you want to get your positivity rate to go down, you just test as many people as possible. So many are going to be negative, and your positivity rate to come down. Okay, so it's how sensitive your definition is and how you are looking at it. We believe that, like I keep telling you, if you don't test them, they'll fall sick and you see them. So, but we are not getting that. And so we will see how we go.
Kwame Sarpong, I'd like to come to you. I look at the positivity rates for the new cases, and like I told Dr. Patrick Aboagye, I don't get the level of comfort that he has. And I also feel that by giving people the impression, I get that the Ghana Health Service in recent weeks is trying to get people to appreciate that the situation is under control. Don't we risk a situation where we give people some comfort that things are fine because our active cases are going down, and so they go about, or they refuse to observe, or then they begin to not follow the protocols? Kwame.
Yeah, thanks. I want to situate one thing before I come to what you've just asked, and that is about the transportation in public transport,
yes,
the buses and all. If you look at our cases, and just to point out to Dr. Aboagye, I get all the situational reports, it's regional, everything, and I have them, and I've just been looking at a few of them to point a trend. If you look at our numbers, you'd realize that majority is in Greater Accra, and then next is Ashanti, and then you have Western and Central. If you look at it critically, these are the travel routes from Accra, which is the city center. So a lot of people travel between Accra and Kumasi, Accra and Cape Coast, and Accra and Takoradi. So you realize that generally, but when they've gotten to Kumasi and all that, you see that the reverse travel, like Dr. Aboagye rightly pointed out, to say Western North, to Brownhaven, because the trade routes are not that much, they are not getting a lot of spread. And rightly, like it's been pointed out, you realize that in a lot of those regions further away from Kumasi, you don't get that much compared with, say, Tamale, which is another travel route from Kumasi. So that in itself gives a bit of anecdote that there is a lot of transmission due to travel and human movement. So much as I can agree that they have been tracing the contacts, and the contacts haven't been testing positive, it could also be that we are missing some. Otherwise, when the disease arrived in Accra, there was no way to move to Kumasi, Takoradi, and all the other ways. It moved because of human movement. And in that human movement, majority of it was by vehicular travel because our air travel is not that much.
Kwame, but that does not mean, that they got it. It's about activity. If you are in London, you are in the UK, those in Leicester, did they get it from London because people move from London to Leicester? It's the activity within. The more active the community is, the more people are moving and working. That is where the transmission is. So let's not
Dr. Aboagye, if you heard what I said I totally agree with you, but there is also evidence around the vehicular traffic. So we need to monitor both. That is the point I made, that if there wasn't any evidence, that pattern that we're seeing in Ghana, even in the situational reports, would be non-existent. But it is there because there's much more travel between Accra and Kumasi, or Ashanti and Greater Accra region, than there is between even Greater Accra and Eastern region, surprisingly, because of trade routes and Kumasi being the second city. Likewise, there is a lot of travel between Accra and Tema and Accra and Takoradi than many other places. So we need to look at some of these things. Now, coming to the question you asked around, am I as comfortable as Dr. Aboagye is? Dr. Aboagye would know I am not. And even my elder brother, who is the one you're trying to get on, Dr. Asiedu-Bekoe, is actually my elder brother.
Okay.
Am I as comfortable as Kofi is? I am not. And he knows that. And for me, I say it and situate it as it is. Why am I not as comfortable? I'm not comfortable because of the positive test percentage, which has hovered around the 20% mark for up to 4 weeks. I take the viewpoint that Dr. Aboagye is making, that is because of our strategy and the fact that we're testing people who are arriving in our health centers sicker. However, that has been consistent, which means that the people are getting sick and they are arriving at our health centers. So, because you must get the virus from somewhere before you arrive at our health center. The good thing for us is that a lot of our cases have been mildly symptomatic. I struggle to use the word asymptomatic, and I think I've explained it. They are mildly symptomatic because most of them will get the loss of smell and taste, which is a symptom, but a lot of us ignore it. And that's why I tend to stick to mildly symptomatic, because a lot of people would even have a slight temperature. They would mistake it for malaria. Because they are mildly symptomatic, they might not have a caseload on our Ghana Health Service or on our beds and all that. But there's a lot of research coming out about the hangover effects of SARS-CoV-2 around pulmonary fibrosis, around end organ failure, around renal failure, around kidney failure. In fact, there is a lot. I have seen a paper looking at 100,000 mildly symptomatic cases of COVID across the world, not just in one country, and all of them get fibrosis of the lung. All of them get fibrosis. When you look at their lung x-rays, you can see the fibrosis forming. As a result, there are a number of universities, I think Leeds and Oxford are leading that, and also University of London, who have commissioned studies to look at how these things would progress. Why does that not make me comfortable? Already we have a health system that is not robust enough because historically, and it's not down to the Ghana Health Service at this point in time, historically, our health investments have not been where they're supposed to be. If you look at our spend to GDP ratio, our health expenditure as a proportion of GDP is around 5.9. The Abuja Convention says 15%. We are never going to get there. So you don't want to case load a health system that is not going to get the health investment that is required as per the Abuja Convention with a hangover of chronic diseases. Then let me come to the final thing that doesn't make me comfortable as Dr. Aboagye is. I'm sitting in the UK, as Dr. Aboagye always refers to. The point is that I travel a lot to Ghana. This is the first year that probably I've not been to Ghana 3 times and it's already August. I am not going to be ever able to travel unless the prevalence rate in Ghana is equal to the prevalence rate in the UK. because that is what the principles of air bridges relies on. And until we have air bridges, nobody can travel within the countries, because if you travel, you've got to quarantine in Ghana, you've got to quarantine in the UK, which means if I'm coming for a meeting in CDD, I want to come and visit my dad, I have to, if I'm coming for a week, I have to put away 6 weeks, 2 days to travel in, 2 days to travel out, 4 weeks of quarantine. I work in senior leadership. I cannot take away 6 weeks. But more importantly, that would impact on direct foreign investment and investors visiting our country and our trade, which is important because we are saying our economy is teetering on the edge. But if we look at our economy, disproportionate, our monies that fuel our GDP growth come from all these institutions and come from the Bretton Woods institutions. The universities get a lot of collaborative work done with other universities. So when I look at all these, and I know that the real numbers that these international organizations will be looking at as to whether they should be able to travel to Ghana are not just what Dr. Aboagye and myself would look at locally, but the global picture to say, can we be part of an air bridge arrangement? I am not comfortable because I know it's going to take a very long time for even anyone to consider us for an air bridge. Today I made a post on Facebook, and you can go and look at it. The whole of the United States is virtually blacked out from any air bridge arrangement. They cannot travel anywhere. When did anyone think that US, which refuses disproportionately more visas to anyone from anywhere on this planet, would be shut out just by a virus? Look, and these are the things that make me passionate about what I'm doing. It is not about punching holes. It's about looking at the global picture and looking at a lot of things, looking at the GDP, health investments, looking at the disease prevalence, trajectories, looking at how the economy would open up and going, boy, I cannot be comfortable. And so that is the answer to your question, Israel.
Now, Kwame Sarpong, now let me just put a question to you before I let Dr. Asiedu-Bekoe come in. You talk about the fact that from the way things are going, yes, you're not comfortable with the fact that we may end up with a lot of people with chronic diseases, essentially, if that's my understanding of what you're saying is. So yes, they may not even report to the hospitals, they may not have the serious or severe symptoms, but they would have the mild symptoms, and yet subsequently they would have to live with some chronic disease. How can that be helped if we were testing more? So essentially, if we test 100,000 people, and yes, we find 90,000 being positive, asymptomatic or mildly symptomatic, how can we help the situation? Because they're still going to be left with a chronic disease.
Yes, we can help the situation by the way we communicate to them. It comes across to me that a lot of the citizenry think that, oh, about 80–90% of our people would never be hospitalized or even isolated and can be managed at home, so that is good enough. They do not have an understanding. Yes, they do not seem to have a good understanding of these hangover effects. That is my personal observation. I might be right, I might be wrong. Dr. Aboagye might disagree with me, and that's absolutely fine. That's the beauty of having these conversations. And so I have no problem with him disagreeing. But what I'm trying to say is that the truth of the matter is we don't know. No country in this world actually knows the true extent of the prevalence of COVID in their population. And so if Ghana doesn't know, that's fine. Because even in the UK, now that they've started using antibody testing to try and estimate the prevalence, they are finding out a lot of people who never tested positive for COVID, but have antibodies, which means they were exposed. And that is where all these lung x-rays and chest x-rays are coming from. And then they are taking the data and realizing, say, whoa, wait a minute, this is what's going to happen. And that is where my unease comes from. All right. So if we even test the whole country, unless people comply with the protocols and do not get infected in the first place, we cannot stop that. Even with the best will in the world of Dr. Aboagye, he cannot. Okay, so for you, Kwame Asiedu, you're saying that you would want us to do the communication to get people to be more, adhere to the protocols rather than thinking that everything else is fine. Dr. Patrick Aboagye, do you worry about the post-COVID situation where people are going to be left with a lot of chronic diseases?
Yeah, thank you. Yes, we are looking at that. We are also doing our immunological tests for people who are recovered. And like he himself said, getting the positivity is not necessarily, or that you'll be able to avoid those post-COVID effects, which we are also aware of and which we are going to look at. Our information, our position is the fact that we are putting fewer positives than before. We are also not going to lie to the people of Ghana and tell them we are getting more cases when we are not. But if you have noticed, we've always mentioned that the most important thing is that it's coming down not because God has been good to us. It's not because the sun is hot. It's because we are increasingly seeing more people adapting to the protocols. And that's why we are continuing to push. You see, in cases, when HIV came, when you scare people, they don't tell. Also may also lead to complacency. So you need to give people the information, their right information. And so we are telling that the system is coming down. It's coming down because we are doing this, continue doing that. And we've never forgotten to ensure that we employ and tell people to look at the protocols. And so that's what we are saying. But we are not going to just raise a scare in a district where you have not reported a case that you have cases to wear masks. We are telling everybody to wear the mask. Take the responsibility of protection to your hands. But we also don't want to make it look like we're creating a lot of complacency, or also creating an undue fear, which also has its own effects. And so that's how we are looking at it. We are also looking at the case management team is also following up on those effects, on the post-COVID effects. And we are currently looking at them globally. We are all working towards ensuring that we are able to.
All right, I have Dr. Asiedu-Bekoe.
Solutions and remedies to contain those things.
All right, Dr. Asiedu-Bekoe's hand has been up for a while now. Let me bring him in.
Yes.
Dr. Asiedu-Bekoe.
Yes, I think it's good afternoon.
Good afternoon.
Yes.
Good afternoon.
So
well, you know your brother is on the line.
Yes. So good afternoon to my boss, Dr. Aboagye, and Nana Sarpong, and Dr. Boateng, and Israel. I think that I want to situate this conversation in the context that if you're looking at data, look at it in a context. And let me say that for Ghana, our case burden is premised on the way we are collecting the cases. There are cases in West Africa that have less than 500. The thinking is that, are they testing? If you do not test, you will not get it. That's one. It's just a general statement I want to make. The other issue is, I think that if you talk about a disease like HIV, the early stages, it was focusing on the testing. And then the idea was that let's assume that everybody is HIV positive. So you need to have a particular kind of behavior change to make sure that you don't get the disease. And I think that those kind of concepts must run through our minds. If you look at the Ghana data, you want to run our epic curve, which is not the typical epic curve. Typical epic curves for outbreaks are situated on calculating cases over date of onset. For this disease called COVID, and the way we are monitoring it, we are not even looking for onset of symptoms. So you need to have a proxy. So we are using a proxy called the date sample taken. And let me be clear. Most of the analysis being done is based on the date of lab results, which is far off the discussion. Because let me be clear, if I today, I think today is 2nd of August, if I'm ill, it's likely I'll go to the hospital the next day and my sample will be taken. But because of the challenges we have at our lab system, the lab results will come 2 weeks. So if we want to use that 2 weeks to make analysis of the trajectory of the outbreak, you are way off. And I think that it's an issue we need to discuss, because the discussion for the context of the outbreak in Ghana must be based on which people have the disease. if you get the results after 2 weeks, you cannot use it as a discussion. More especially now that we have the evidence that the virus is not likely to be infectious after 10 to 14 days. So if you are talking about a disease burden after 4 weeks to 6 weeks, then you need to be very careful. But let me stress that COVID-19 is a disease that when you are discussing, you need to be very humble, because it's a very novel virus and it keeps on changing. So let me go back to the scenario. Ghana has 4 prominent, let's say, regions: Greater Accra, Ashanti, Central, and Western. But they are unique in their perspective. And I think that it's about contact, it's about activity, because the way that the virus is spreading is about how close you are to somebody, though they have issues about aerosol spread. So for now, as we situate our outbreak in the country, our challenge has been in Greater Accra, where there's a high population density. There's a lot of interactions between the populace. We, as a country, have said that we are testing the Ghanaians, but I cannot test every Ghanaian. But the issue is that the answer? How often are you going to test the average Ghanaian? Because when I'm negative today, would I be negative tomorrow? So that's why we are pushing for the adherence to the safety protocols. The thinking that, assume that every Ghanaian could be carrier of the virus, and you need to prevent yourself from getting the infection. That's the thinking that we want to push to the average Ghanaian. And let me be clear here. In as much as the government is trying to push and try to support the response, the focus on the average Ghanaian has been very minimal. What we are seeing is the complaint. So you see about 100 Ghanaians and 20 are wearing face masks, and nobody talks about it, and whether they're talking about the figures going up. How will the figures go down if nobody's wearing the mask? So I was saying that, I think that I've said this about 2 months ago, that the fight against COVID is responsibility which is on the side of the individual and the government. Because so far as we don't have a vaccine, we don't have a creative agent, the surest way is make sure that we are observing the safety protocols. But let me go on to talk about the positivity rate. And I think that is very important in the context. Very early in the outbreak, our policy was to identify those who have the infection or the disease. So we were using the case definition. Let me be clear that Ghana is one of the few countries that use a very loose case definition, that we're using an ILI. That's like the influenza-like illness. The best was even using the SARI, which is severe acute respiratory infection. So in that case, you need to be very ill for you to be detected. Ghana was using the very minimal one because we wanted to pick the cases. Then we said, that does not give us an idea of the magnitude of the outbreak in the country. So we went on to say, okay, let's do a community spread assessment. So that's why we said we want to do the sweeping. So in that context, people who are living in their houses, who are less likely to get infection, are likely to be tested. And when you put them all together as a denominator, your positivity rate is very, very low. Moving on, with the advent of the stress of getting the testing done, and we trying to prioritize, now our focus is on getting people who are likely to be COVID positive. Being COVID positive is different from me staying in my house and being tested. So the positivity rate differs. So if you want to compare positivity rate, you need to be sure that you're comparing likes to like. Because across the country, we never did a prevalence rate to say that the prevalence rate has changed. It's when your prevalence rate changes, then you can talk about it. We didn't do a prevalence rate, we did positivity rate. And it depends on how many people have been tested. I want to stress that clearly, based on anecdotal evidence, there's a lot of evidence that people in the communities are getting it. But the issue is who people are testing. When you are in Lab FM or Joy FM, I don't know, you are 200, and I'm sure you test. Maybe your positivity rate could be about 2%. Is that representing the country? Unlike when you go and test people who are presenting to Kolebu or Kofarachi, the positivity rate will be different. So I think that we need to get a context of positivity rate and see how does it reflect the situation.
All right.
But I want to say that we need to be sure that the average Ghanaian is fully on board. That we can only avoid COVID when you are fully observing the safety protocols.
All right. Thank you very much, Dr. Asiedu-Bekoe. And I'm looking at a number of factors that have come up. We're looking at the challenges we're having with doing as many tests as we may want to do. We're also looking at people's failure to observe the protocols and the plethora of issues that have come up. And I'm asking myself, I want to throw this to all of you, starting with you, Dr. Bediako. Should we be looking at herd immunity? I've heard something like herd immunity. Is it something we should be contemplating?
No. To put it frankly, Sweden tried that and it hasn't worked well. The UK started with that and it's been a disaster. I mean, I guess I'm the immunologist on the panel. So,
okay, so Dr. Bediako, the reason why I'm probably bringing it up is if people are having COVID and they're mildly symptomatic, and so they're not going to the hospital, so we may have, 37,000 cases, but we probably may have a whole lot more people, many more people in the community with the virus, but they're not coming to us. We're not testing them. Shouldn't we just probably say, well, let's let the people get the COVID. A few people will die, and the rest of them will have immunity.
I mean, I think, no, I think that would be a very dangerous strategy. And I don't think that is what the Ghana Health Service is going for, because the evidence suggests, all the data suggests that in order for herd immunity to take hold, you need between 60 and 70% of the population to be positive. And that is assuming that immunity is long lasting. There is evidence suggesting that COVID immunity may actually not be sterile, in that it doesn't last for your lifetime as other viruses can do. We don't yet know. It appears antibody levels decline quite rapidly. Studies we are even doing here at the University of Ghana, looking at antibody levels in people who have tested positive, shows that over a course of a few weeks, their circulating antibody levels will drop. Now, there's a lot of talk about T-cell mediated immunity, the fact that even if you don't have circulating antibodies, perhaps you may still have some immunity to COVID. It is not yet very clear in the field worldwide what immunity to COVID really means and how long lasting it is. But if immunity is short-lived, as it is with other coronaviruses, COVID is novel, but we have other coronaviruses that we deal with on a regular basis that cause common cold. Those immunity to common cold is short-lived. So if immunity to COVID is similarly short-lived, then that means herd immunity will be almost impossible to establish, because herd immunity presupposes that once somebody is infected, they are protected permanently. So I don't think herd immunity is a viable strategy. And I think, till we have a vaccine, like Dr. Asiedu-Bekoe has said, we don't have a vaccine, we don't have, I think we need to get away from this thing that there's a treatment for COVID. There is no treatment for COVID. There is no vaccine for COVID. People have recovered, but the recoveries are less about what we have done for them and more about what their immune system over time has been able to do. And unfortunately, some people do not make it. Obviously, being able to have ventilator care if they need it will give their body time to fight off the disease. But as an immunologist, I'm always arguing with people that there is no way to treat COVID. It is just, you're basically, once you get infected, you have thrown the dice. And thankfully for a large number of people, they recover, although as Kwame has talked about, the downstream effects are yet to be really fully understood. But, as much as possible, and I think this is where the Ghana Health Service has kept on hammering, that we need to, as much as possible, prevent yourself from getting COVID by adhering to the guidelines, to the social distancing, because getting COVID is a gamble. But I think, we've been talking about the positivity rates. I take Dr. Asiedu-Bekoe's point that we are looking at 2-week-old data. And I think that's a huge problem. If we don't, if we are saying that the date sample was taken is the denominator, is the number, is the statistic that we are focusing on, and this is at least 14 days ago for many of the samples that we have, then we can't really know, in my opinion, where we are today, because we will know where we are today in 14 days. And so that creates a problem for policy making and for strategy. So I think Dr. Asiedu-Bekoe has sort of hit the nail on the head in the challenge that we have in Ghana. And I think Dr. Aboagye himself said that right now the focus is on trying to get the test lag down to 48 hours. I think once that happens, then all of this argument about date test was taken versus date test was released will no longer be valid, because test sample taken date and test sample release date will be almost the same. So I think in terms of positivity, we are arguing about, are we getting better or are we not getting better? I really think based on this discussion, what I've left is we don't know. Because if we say the positivity rate is 20%, you tell me that was 2 weeks ago. Okay, so what is the positivity rate today? I'll have to wait 14 days to find out. So I think the challenge we have is right now, we need to improve our test speed and get an idea of the current state of affairs so that we can actually put a point and say, yes, Ghana is improving or Ghana is holding level. For me, it looks like the number of active cases is flatlining. That is driven a lot by number of tests and by discharge. And we are discharging every 14 days. So that is a constant discharge. So I think what we have to focus on is the positivity rate. But it's difficult to do that if we are dealing with data that is 14 days old, as Dr. Asiedu-Bekoe has pointed out. So I think right now we are at a point where we need to improve upon, and I think that is certainly clearly what the Ghana Health Service is trying to do, is improve upon how quickly we can get the testing done so that the data that Dr. Asiedu-Bekoe and his team are working with is no longer 14 days old. But then I think Kwame made a really good point. It's something I've thought about for a long time. We keep focusing on the economy, but if Ghana is labeled as a hotbed of COVID, it doesn't help our economy. Because nobody will want to come here. Right now, Kenya has opened up. They are not flying, they are not allowing Ghanaians to come to Kenya without 14 days of quarantine. There are a number of countries that will continue to begin to do this. So it is in everybody's interest for us to minimize the spread. Herd immunity, I don't think is the way to go. We need to do everything we can to slow down the spread of the virus. Eventually, if we do adhere to these measures, I believe we can overcome this virus and we'll get our transmission down to zero. But it's going to take time, and it's going to take a serious awareness on the populace. And so that is the question I have, maybe, and I'm not taking your job, Israel, but the question I have is, if we tell people we have it under control, and we tell people that things are getting better, but at the same time, we want them to wear the masks all the time, it sounds like a mixed message. I'm not talking about inspiring fear in people. Fear doesn't help. But if people, if people hear that things are getting better, then naturally we begin to take our foot off the gas because we think that what we are doing is working. But in actual fact, what we need, and what I'm hearing everybody say, is we need to do more. Everybody in a trotro should be wearing a mask. Everybody in a banking hall, everybody in town should be wearing masks. We should be wearing more masks now than we were wearing 2 months ago. So to me, that message has to be then that we are in a serious fight. We may not be losing, but we are not necessarily winning, and we need to keep pushing hard. Right. So I think that is for me the message that has to come out, because we need the populace to take responsibility. And I wonder whether easing restrictions doesn't send a mixed message, because when you ease, it suggests that things are improved, and so we are almost there, and so people relax, and we don't need people to relax right now because we're actually in the thick of the fight.
All right. So thank you very much, Dr. Bediako. Now I'm coming to you, Dr. Patrick Aboagye. I naively suggested herd immunity. Is that something that would want to consider?
Well, there's never ever considered herd immunity, because it's a very, very dangerous route to go, especially in a virus you don't even know how its behavior is. And so that is not what we are looking at. But I'm sure eventually, not for a long time. And so we're going to, but that's not something we're going to work towards. And then I just also want to add, yes, we don't want people to be complacent, but we are also telling people must also believe that when I wear a mask, it protects me. And so when we started increasing the awareness of masks, we sell it's a message to go. That we also want to keep that we have been wearing masks, nothing has happened. They say the thing is getting bad. And so if things are changing, they should know. They should know that it is helping because we are doing that. And we must give the praise to the people who are doing that. And I believe that from all our assessments, relatively an increasing number of people are adhering to the protocol. And that's why we want the media to help. Because people must believe that if I wear a mask and I'm struggling with headaches and breathing difficulty and it's protecting me, they will. But if you feel that, well, I've been wearing masks for months and nothing is happening, why don't we too? So it's a very balanced, it's something that probably we need to get our way around and see how we keep the message back coming down. People are wearing more, adherence to the protocols are increasing. If you go to the churches, they are the best. They adhere strictly to that. The schools adhere to them. And so we can now push that to ensure that people also, we don't also create any undue panic and fear that makes people that, well, we are tired, we stop wearing. We've seen what's happening in Europe, who are demonstrating that the restrictions are too many, they won't wear masks anymore. And so we need to really balance this and make people also believe that protocols are helping them to reduce this thing. In terms of the positivity, I think Franklin mentioned this. We are looking at the date sample is taken. And so I'm not saying certain example if it take 2 weeks, but it doesn't really take 2 weeks. That's why we are giving you the positives. If you look at the all updates, the positives for a party reporting that day, and it goes back to 32. But you can also see that a larger number of the samples that are being reported, they used to be wider, but now since we started getting it, you can see that it's narrowing and we're having a close-up in terms of the number of days that it takes for samples to come in. And so, especially now that we are also spreading the number of testing sites, if you take a sample in Western or let's say BR district, it probably will take you the following day before you get to the KCCR in Kumasi, and before they also work on it. But with now that we are bringing more testing sites closer to the people, even the travel time from the time sample is taken to reaching the line, also another factor that we can reduce, and based on that we're able to reduce the turnaround time to be more efficient, and that's what we are working on, and based on our policy. Also, secondly, in the comparison, because every country has a different testing policy and approach, comparing positivity among countries becomes very, very difficult. And so let's look at within our country and see how we can also reduce our own positivity rate within our current policy, which is what I believe that Kwame wants us to do. So thank you very much.
All right, so I have some questions or comments on Facebook which I'd like to share with you. So we have Isaac Dupont. He says, when the communication starts to focus on possible complications post-COVID, even for asymptomatic cases, it may help with adherence to the protocols. Divine Akaba says, how can there be a disagreement on the positivity rate? Numbers don't lie, as they say. Mame Ya Nyanko says, seriously, I'm not sure people are complying to the protocols. Rather, many commercial areas have even stopped providing hand washing points, and many are wearing masks at the chin, which is a point which needs to be emphasized, because people may be wearing the mask, but they may not be wearing them properly. And even taking them off too, they may not be doing so properly. Then we have Amma Ohima says, what are Dr. Aboagye and his team communicating to the policy makers about the lack of adherence to the protocols? Example, in Swam and its environs, less than 10% of people you meet wear the face mask. And so these are some of the comments that are coming up. And then Kobe Blay, he also says, key problem, open targeted communication. I wish you'd be a bit more elaborate on that. But these are some of the comments that are coming through. Dr. Aboagye, how do you respond to that?
Well, I think most of them were comments and contributions to what we are looking at. Yes, we are working towards improving the adherence to the protocols. It is a countrywide assessment and all government approaches, and everybody must play their role in ensuring that people wear their masks. If 10% of the people are wearing masks now, what was the percentage, let's say, a month ago or 2 ago? I think those are the things that we need to look at and see how we can also encourage. And that's why we are working at our chiefs and other people to encourage more people to adhere to the protocol. That's the only way around it. Otherwise, we can do the supply of everything, but if the demand side, if people are not protecting themselves, it becomes extremely difficult to look at. And you can see that people celebrate July 4th and they get the surge on it. People go to their beaches because they are not following the rules, and then they get a surge. And so it's a two-way approach. The people must take the responsibility. That's the only surest way of looking at that. And you are positive, it will come positive because you are not protecting yourself. And I think that's really the drive that other parts of everybody in the country, including the media, should really be driving at ensuring that the people take up that responsibility of protecting themselves and their people individually. Otherwise, we can continue testing, we can continue expanding treatment centers, isolation centers. It will be an ending business, but people must take up that responsibility. And I hope the next discussion will focus more on that and come up with more communication strategies that will help people adhere. Because I'm sure the media may be getting more money because of adverts from COVID, but other aspects are something.
We're not getting more money because of adverts from COVID. But we'll come to the communication in the last 10 minutes. But one issue that has come up in the past week is hydroxychloroquine, which people are saying that, it's a cure. I'd want, now that we have you, I'd want us to have that conversation to get people to appreciate. What is Ghana's position on hydroxychloroquine?
Israel, what I'll tell you that if it is so simple, there'll be no argument. If the evidence is so clear, there'll be no evidence, there'll be no argument. Nobody is doubting that antibiotics can kill some bacteria. And so, which means that there are issues around it. What we are looking at is that we also using our treatment, the FDA and in a trial to see, okay, comparing those who are on hydroxychloroquine and those who are not. And then very soon the report should be out. And then who, as a Ghana, will know whether taking hydroxychloroquine improves your outcome amidst the other risk of your effects on your heart and etc., as opposed to those who don't just take others without the hydroxychloroquine. I think that would be the best way for us to say that the proportion of people who took hydroxychloroquine, if their survival rates and their clinical outcomes was better, then we'll review the policy. But for now, we're still collecting the data. And I'm sure very soon, we've been collecting the data for months now. Very soon, we'll also be able to do the analysis and share and see what our position will be. But I believe that if it is so straightforward, we will not have all this heated argument globally we are having. Thank you.
But clearly, hydroxychloroquine is something that we're using as part of our treatment protocol.
Oh, yes. We've been using it for a while, but we're also doing a trial as well, so that we don't give to everybody, we give to some, so we can be able to compare and take a more definite position and see that if it is beneficial, then we take it. If it is looking at the costs, I mean the cost-benefit analysis, the cost I'm not talking about financial costs. Maybe the effect of cost will be part, also side effects, etc. Is it worth adding it? That decision will be made once we review the analysis of the report.
All right, I'm coming to you, Kwame Asiedu. So what's your position, or what do you make of this conversation about hydroxychloroquine?
It's an interesting one. I'll address that, and there are a few things I want to address. I'll address that as a pharmacist and someone who has worked and continues to work in the area of drug analysis and quality control and biomedical pharmacy. So I'm going to look at the fundamentals of hydroxychloroquine and chloroquine. It is known that cinchona alkaloids, from which chloroquine and hydroxychloroquine comes from, have antiviral properties. It's been demonstrated in the lab, and that is known. So that's one. It is also known that when taken with something like zinc, which also is known to have some amount of antiviral property, there could be what we call some synergy. That's also known. It is then thirdly known that when you take it with vitamin C, it increases the concentration of the zinc in the cell, and therefore increases what we call the virostatic, because they don't kill viruses, they slow down their replication. So don't make them multiply enough until the immune system can take it over. And when you give it with vitamin D, which is an immune booster, then your immune system can quickly reinvigorate itself and probably take over the viruses. But all these things are known theoretically. Practically till date, there's no real scientific evidence to back the fact that putting all four together gives you a better outcome. The jury's out, like Dr. Aboagye said. Yes, I've seen this whole arguments have started, especially with the US video coming out and all that. And I have held the position that in things like this, I would rather have what we call a randomized controlled trial, like Dr. Aboagye was suggesting, where some have taken it, some have not taken it, and we look at the treatment outcomes. But more importantly, in a statistically significant sample size. Because if you did it in 100 people, 200 people, it would not be statistically significant. So it would be good if Ghana can come out with the information. Because like I said, when it comes to the theory, I don't doubt the theoretical machinations. And that is why chloroquine and hydroxychloroquine became candidates in the first place, because they had these things. So basically, because no one had a treatment, all these things were cobbled together based on their potential so that it will give a synergistic effect. So that's that. What I wanted to come back to is this whole issue of herd immunity. Anytime I hear it, I laugh. And I think Dr. Aboagye and Yao have handled it well. But there's one thing that the public who are having the conversation should know. Currently, our case fatality ratio has number, which is the number of people who died from COVID compared with the total number of cases, is around 0.5. Sometimes it goes slightly to 0.6. Like Yao said, if you want to know what constitutes herd immunity, there's a simple mathematical formula, which is the reproductive number, the average reproductive number, divided by the reproductive number plus 1. So if you take COVID, the R naught averagely is set to 3. So you need about 75% because it's 3/4 to actually get herd immunity. That is even if the effects you've got that it would persist, and we know that it doesn't persist, it wins. But what does that mean for our population? It means for a country of 30 million people, you have to have about 22.5 million people infected, and pretty rapidly before we get towards herd immunity. But more importantly, with our case fatality ratio of 0.5, we should be prepared to lose 135,000 people dead from COVID to get there. I don't think anyone is thinking of these things mathematically this way. I don't think any of us is prepared to volunteer to be one of the 135,000 people who would die if we go down this route. And that is why, for me, anytime I hear that conversation, I'm like, clearly someone is not looking at the modeling, and someone is not really availing himself to the reality of what they are talking about. Otherwise, it wouldn't even be a conversation to start with. So for me, this is where we then move into the communication, so we can demystify some of these things that people are saying using real numbers and ask them real questions to their face if they are prepared for things like this to happen. And that is what, for me, moving forward should drive our conversation. Because if you know the chronic disease overload, which we know is still being studied, if you know that you could potentially die from it, if you know that herd immunity is not an option, then the only thing left is wash your hands, cover your mouth and your face, social distance, and avoid crowds. It's as simple as that. I don't see any way around it until we get a vaccine. Even when you look at the vaccine research, like Kian said, it's a lot of things about training of the T cells and other things, like the data coming out from University of Oxford and a bit of seen from Imperial College as well. But we don't know how reliable this is going to be. So even gambling on making yourself a guinea pig, and I said this the first program I appeared on, I said, in this journey, anyone who gets COVID is just a guinea pig. You are being used as a lab animal to try out things that would work in the future for humankind. The best bet is, if you don't want to be a guinea pig, try and avoid it. And the way to avoid it is to social distance.
This other issue, which a bit controversial, you can say, but the policy now is that government takes out the bills for the treatment of persons with COVID-19. But is this something we intend to do, or is this something we want to do in the long term, or at what point do we want to stop it? Because it was a great idea at the start of the pandemic when we wanted to ensure costs would not be a barrier in trying to contain the pandemic. But now that we have people who are able to pay for their treatment, shouldn't we let them pay for it? And especially when government is constrained when it comes to funding. Dr. Aboagye.
Thank you very much. I think that has been a debate. But when you have a pandemic, you don't leave those issues to the individual. Because so if I say, because I don't want to pay, you become a risk to others. Yeah. And so I believe that this approach currently is the best in an infectious disease like COVID, where, I mean, if you have some insurance cover, but of course our insurance current COVID, DRG doesn't cover COVID unless you change the rules, you know. So these are all the things that we need. But the thing is, I don't want to leave such an important spread into the individual, okay, and so that there's access is removed, so that everybody can get care, and then we can also protect the next person. So I believe for now, I think it's a good policy, but I'm sure going forward, we'll look at it and see how best that can be done, because we don't want a situation where, because someone doesn't want to pay, it puts everybody else at risk. And that's how governments are supposed to come in and make sure that everybody is protected.
All right, Dr. Bediako, do you have a point on that?
No, I think in this case, I actually agree entirely with Dr. Aboagye's point that it's a pandemic. At this point, the social good or the public interest outweighs personal preference. I think you could include, maybe we could get creative and find ways where, individuals who have the means could volunteer to pay. So the option is there for the government to pay, but, if you have the means for the good of the country, you want to allay the bill, I think that avenue could be provided. Okay. But I think it's important that people, the whole point of testing is to identify infected people and isolate them from the population. And so you have, that has to be provided for one way or another. I think that, so I think I don't really see a way around that without the government having, a mechanism to take care of that. But certainly if people have the means, that could be something where, I guess, through advocacy, people could be encouraged to foot the bill themselves to free up resources for those who may be less fortunate. But in that, in this case, I think the government has to at least be prepared to do it as part of the process. But perhaps going forward, this would inform our insurance coverages, so that if something like this were to happen again, hopefully it would be covered under insurance.
All right, so I'll be coming to you, Dr. Bediako, finally, for how you feel we should craft our communication going forward. But Kwame Sarpong Asiedu, what do you make of some people being prepared to take up their own bills?
You see, it's a very tricky one. It's like all have said, it's a pandemic. So this is a public health emergency of international concern. So once the WHO issues a pick, then the onus falls on government to fund everything, because an emergency has been declared. Having said that, when I see some of the numbers coming out for the cost of COVID management, and I look at our health expenditure per capita, which is the average amount of money we are spending on each citizen, which is around $71, I also struggle to see how government can fund it indefinitely. That is where a lot of my anxiety has been coming from. Because when you do the numbers and you see that, whoa, if we get to a point where even we have, and I agree with Dr. Aboagye, we shouldn't look at the cumulative figure, but if we have a cumulative figure of, let's say, 50,000, and of that, 20,000 were managed in some form at that cost, with all the testing and all that, at what point would government be saddled with a bill it wouldn't have the capability of paying? Because we're not a country with a bottomless pit. So it is very, very tricky. Very, very, very tricky. It's not something that you can easily say, but for now, yes, government has to pay. But government also needs to come out and tell us early enough if they think they're heading for a cul-de-sac. Because if the citizenry don't collaborate, and if the citizenry don't drive the infection prevalence and rates down, then government is going to go into a cul-de-sac. And that is something that none of us would want.
All right, I have a question coming in from Jasper Sabla, and he says, shouldn't the easing of restrictions be informed by how well safety protocols are being adhered to? Don't know what informed the current decision to ease some of the restrictions, particularly for the public transport sector. But looking at the apparent adherence rate, it is potential recipe for disaster, which brings me to the point where I would want us to end with. How do we shape the communication? There has been the issue of, do we scare the people? Do we let the people know that this is a terrifying disease? And if you get it, you're going to have complications, or you're going to be living with complications for many years to come. Or as the Ghana Health Service would want to suggest, yeah, if people have done well in complying, and we have been able to succeed in bringing down the number of active cases, we should let them know. I'll start with you, Kwame.
Well, I'm someone who believes that you communicate to human beings through hormones. I mean, there's a lot of body of research. And the human being is modulated by 4 hormones: serotonin, oxytocin, adrenaline, and dopamine. Everyone has a role to play. We are in a state of war. And therefore, you communicate to the reactionary hormones, which is adrenaline mainly, and dopamine, which is the reward hormone, because then the person knows that if I do this and I do it correctly, this is the reward I'm going to get at the end of this thing. My belief is that we started too early communicating to oxytocin and serotonin, the hormones of love and care. Oh, spread calm and not fear. So we didn't get the balance really right. I don't want people to be scared, but I want us to target the hormones that drive our behaviors. No one would go into a war wanting a scared army. But there's a reason why when people are going to war, they take a much younger army corps who are high in adrenaline and also communicate to them in a particular way. And at the end of the day, give them medals as war trophies. That is how I believe we should have styled our communication. I don't think we did that from the outset. And these things happen. If you read things like the end of pandemics or even the WHO communication protocol, these things are clearly explained in them. And so maybe we would have to start shifting and communicating and targeting the hormones using the press, because you guys would have a lot to do with this.
All right, Dr. Bediako, how would you rather the communication was shaped?
I mean, I think there needs to perhaps be a communication of greater urgency. I think complacency has definitely set in. I know none of us on this panel want complacency. I think I've heard it from all of us that we believe that we are in a serious situation. But I think if you took a polling of the average Ghanaian, especially out of Accra, my mother lives in Mampong, Ekuapem. I went there yesterday. Nobody was wearing a mask. This is the Eastern region. The Eastern region has had cases, right? It's not that far from Accra. Accra mask adherence is maybe at best, I would say, just looking around, probably 40. It's definitely less than 50%. Complacency has set in, and I think we probably all have a share in that blame. But this is not the time to apportion blame. It's now to find solutions. And I think our messaging has to be more urgent. I think we need some of the statistics that Kwame has been talking about. We need to be talking about. We need to explain to people that asymptomatic or mildly symptomatic, you've not won. You may have lost and you pay for it later on. That needs to be clear. We need to encourage people to understand that 30,000 may sound like a lot, but we are 30 million Ghanaians. And if it continues, 0.5% is a big number of 30 million. These are the things that we need to put out there, not to scare people, but to encourage people to adhere to the advice and to be more, I think, more serious about it. I think, and we have to ask ourselves, I think, in general, how, the easing of restrictions, how that is handled and how messaging is handled. I agree with the idea of rewards. Easing of restrictions is a reward. What are we rewarding? Despite the fact that active cases have come down, majority of the decline was simply because we changed our discharge policy. The moment we shifted, you see the graph just drop like a cliff. It was the moment Ghana Health Service went with the WHO guidelines that said after 14 days, people are less infectious. That is largely responsible for the decline. So as much as Ghana Health Service should be commended, I think they're doing a yeoman's job. Doctors across the country, nurses, health workers, people testing at Noguchi and other centers, definitely we are showing what Ghana is made of. But people should not think that we have won. And I think that has to be very, very clear, that we are still in the thick of things, that it is a serious situation. We don't know when it's going to end. The fact that, people are talking about, the virus may be here for a long time. That's not a good thing. That's a bad thing. It's not just like, malaria has been here. Yeah, malaria kills 400,000 people globally every year. COVID has infected how many millions and has already killed how many in less than in a number of months. So I think we have to communicate that urgency and try to, enforce the social distancing, not so much with a stick, because I don't think that necessarily works, but we need to see that urgency. And if people do not adhere, like I think one of your viewers has said, if adherence is not improving, then you take away the reward. If adherence is not improving, then the president has no choice but to bring back restrictions. And people have to understand that. Churches will go back, trotros, you go back to, perhaps in targeted locations where you have greater, bigger problems. So I think we have to be more nuanced in our approach, more forceful, perhaps or more urgent in our recommendations, and then willing, when necessary, to implement restrictions. So take away the rewards to emphasize the seriousness of the guidelines.
All right. Let me come to Dr. Asiedu-Bekoe. Your take on how we should craft the communication going forward?
Yes, thank you very much. I think that Dr. Boate and Nana have tried to situate the situation. If you look at the Ghana situation, it has been, what is the government doing? And the individual has been left on his own. But let me be clear that the cases that we are recording are basically individuals who are getting infected. So I think that we need to be able to couch the message that the individual has able to play. It's about how many Ghanaians are wearing the mask. You need to wear the mask, because if you are not wearing the mask, you are seeing that the figures are going up. Why wouldn't they go up? How are we complicating the issue of social distancing? I think so. As has been said earlier, the government has tried to give a lot of reward, but then what has been the returns for the individual? I think the media have been silent, and I want to urge the media. Let's get an average Ghanaian to know that the war against COVID is based on an individual. There could be an enabling environment, but you as an individual must decide that I don't want to be infected with COVID. And I think that should be the narrative, rather than defining fault with the system. Because as far as I'm concerned, there's a lot of financial input that has come from the other side. But the issue is, how much is the Ghanaian able to turn it around? And that has been a challenge. So there's also this issue about the complications. You could be asymptomatic, but you can have complications. And then I think that narrative must also go around to people that you can have an effect of the virus. So as you said, we are not trying to preach the devil, but there are also complications that come with the disease. So I think that let me ask that the media should be on our side. The fight against COVID is not government and we, it's we together. And let's fight and address the challenge of COVID. Thank you very much.
All right, thank you very much, Dr. Asiedu-Bekoe. And I have one more comment coming in from Isaac Edupong, and with that, I'll go to Dr. Patrick Aboagye. So he says, according to Dr. Aboagye, it's more of activities than mere proximity that facilitates the spread. On the assumption that the protocols are being adhered to, and into bracket, which is not, I'm a bit worried of the seeming non-involvement of limited involvement of behavioral scientists. Looks like everything is left to medical science, especially when human behavior has a huge bearing on our expected outcomes. So Isaac Edupong is making reference to using, or he thinks that we should use more behavioral scientists in our approach. And I'd like to get your response to that and your final take on everything that we've said today.
Yeah, thank you very much, Israel. I think maybe I just have to let him know that this is not just health for medical people. Our behavioral scientists who are doing, working in the School of Public Health, they are looking with a psychologist. There's a whole gamut of people who are part of that. We are working with the Ministry of Information, the NCC, they are all part of the communication. And so it is, maybe if you just focus on the data alone, you think it's just that, but the responses and all encompass. And so our whole promotion division is mainly made of behavioral scientists who are looking at the communications and etc. that is being done. So yes, we could do more. We encourage more people. We also want more people to volunteer ideas to assist in the communication. And we also want the media to also focus more on that and not, you know what I'm talking about, focus more on that. And also so that the issue that how do we address this problem and not who has not done what and who is not doing well. And so I think we need to really, because this is something that affects everybody. I'm glad you tell me that you are not getting more adverts. So it means that even if you don't get a virus, you are getting the effect. And so I think we have to all work very hard to bring it down. In the communication, I think these are the very brilliant submissions that we have had from Asiedu, Dr. Bediako, and Franklin, and I think it's something that we need to look at. We are currently trying to do both, as Asiedu said, as Asiedu said, that we are trying to do both the encouraging people and also telling the people about the fears when they have to. So if there's an outbreak in Obuasi, everybody gets to know that there's a problem here. And so let's do something about it. It's a mix of both. I think we will continue doing that. And we want more ideas. And then we also need to have more platforms that enrich as many people as possible. The churches, everybody must be individual at the center. There are many people who have been at every place where there have been positives. The only reason that their adherence to the protocol is so strict. There are people who, even when they are with you and they are drinking their cup of tea, every sip, you just pull their mask up, sip and close until the tea is finished. You see, and that's how, and I think that's what the kind of adherence that we want everybody to look at. Don't be seen to be paranoid if you are just always using your sanitizer. Even in my office in that house, I have a sanitizer sitting on my table. And I think it is something that we must all ensure that we do. And we are also doing periodic assessment to look at very targeted groups to see if we are seeing a decline in the use or an increase in our adherence to the distance. So we go to shops and see how many shops have the bucket and things for hand washing, and periodically we go there and see whether in the same area we are seeing a decline or an improvement. And so that we continue shaping our messages to ensure that we are able to push more people into adhering to the protocol. But so far, I think people have been, if you know where we started from, I think the adherence has been good. And we need to ensure that, tell people that even though you are in Mampong, either on holiday or visit their parents, you need to also look at that as a risk and that protect yourself. Okay, so I think it's a lot of way that we need to go around this, but we also have to also shape the messages. So if I live in Central Gonja, for example, and I've not had any case there, what is the message we need to put out to ensure that people protect themselves, especially when, for example, there may not have been any case since the outbreak started. You need to also carve their own messages to make them adhere to the protocols. And so I think we need to look at the context and shape the messages appropriately for them.
All right, thank you very much, Dr. Patrick Aboagye. Now, to wrap up, I'd also like to sum up some of the things that have been said. The scientists and medical practitioners tell us all the time that they're yet to fully understand how the SARS-CoV-2 virus operates. There's also no known cure, neither is there a vaccine. The only way we can stay safe is to avoid catching the virus. So keep your face mask on while in public, and you should always cover your nose and mouth. Wash your hands regularly and sanitize when you can't keep a physical distance. So simply put, assume that the next person you encounter could have the virus. So do what you can to avoid catching it. And keeping a physical distance does not mean you're shunning the person. It's because of the times in which we find ourselves. So once again, I'd like to say a big thank you to you, Dr. Patrick Aboagye, the Director General of the Ghana Health Service, for joining us. And as I say, he's the top expert in charge of the fight against the pandemic in Ghana. We also had Dr. Asiedu-Bekoe, also of the Ghana Health Service, joining us. There's also Kwame Sarpong Asiedu, a pharmacist based in the UK, who's also a fellow of the Center for Democratic Development Ghana, and Dr. Bediako, an immunologist and research fellow at the West Africa Center for Cell Biology of Infectious Pathogens at the University of Ghana. Thank you all for making time to join this conversation, and you enjoy the rest of your Sunday.